Hello everybody, I hope everyone is doing well. Today we are going to be talking about the growth hormone and associated diseases with growth hormone. First of all, I would like to kindly ask you to hit the button like and share and subscribe to my channel. Okay, now let's get started. So first of all, about the growth hormone, we should a little bit know about the basic stuff. First of all, growth hormone is an anabolic hormone, which means that it promotes growth in our body. And when we want to talk about the diseases associated with growth hormone, we can divide the diseases based on if they are caused by hyperfunction or hypofunction of the growth hormone. So we have generally three diseases, which are acromegaly and gigantism and dwarfism. Gigantism and acromegaly are diseases that occur due to hyperfunction of the growth hormone, and dwarfism occurs due to hypofunction. And this makes sense when we say hyperfunction will lead to acromegaly, because we know that the growth hormone is promotes growth in our body. So this means that the excessive function of the growth hormone will lead to overgrowth of our body, which is basically the main characteristic in acromegaly and gigantism. And similarly in hypofunction, as we know, hypofunction of growth hormone will lead to decreased growth in our body, which is the main characteristic of dwarfism, because as we know, dwarfism means the short stature of the body, or the decreased growth in our body. Now, what can lead to hyperfunctioning of the growth hormone? So this is usually due to pituitary adenoma, and pituitary adenoma is a tumor that occurs in the pituitary glands, but it occurs usually, when it occurs in a specific cell in the pituitary gland, which will lead to the release of a specific hormone. So what I'm saying is that the pituitary adenoma will not lead to the increased production of all the hormones that it contains. No, it will affect only one type of cell, for example, the cells that release prolactin, and for this reason, there will only be hyperprolactinemia from this adenoma, and other hormones will be normal. And so, the most common type of affected cells in pituitary adenoma is prolactin secreting cells, and this is accounts to 60% of the cases of pituitary adenoma. That's why I put 4 up arrows here. And about the growth hormone and ACTH is the second most common types of pituitary adenoma. The very rare pituitary adenoma to occur is the TSH. And gonadotropin releasing hormone and gonadotropin hormones such as FSH and LH. So now let's mention about what can increase the release of growth hormone and decrease the release of growth hormone. So what can increase the release of growth hormone is like the growth hormone releasing hormone itself, because as we know, the hypothalamus, the pituitary is connected to the hypothalamus, and the hypothalamus will release the growth hormone releasing hormone. From its name, it releases the growth hormone, so it goes to the pituitary and stimulates the release of the growth hormone, as well as the low levels of growth hormone in the body will also feed back to the pituitary, which will lead to the pituitary getting the sense of that there is less growth hormone in the body, so it will increase the release of growth hormone, as well as decreased glucose. So decreased glucose also in the body leads to increased release of growth hormone, as well as exercise and deep sleep. Now, what decreases the release of growth hormone? So we have somatostatin, which is also called the growth hormone inhibiting hormone, which is released by the delta cells of the pancreas, and also somatomedin, which is also called insulin growth factor like 1. Insulin growth factor like 1 is released from the liver due to the stimulation by growth hormone. So growth hormone will work in all parts of the body, but also stimulate the liver to produce to release insulin growth factor like 1. Insulin like growth factor 1 is the hormone that is more contributory to the growth in the body, even more than the growth hormone itself. So when we have too much levels of somatomedin, then this will also inhibit the release of growth hormone. So as we said, that decreased levels of glucose will lead to increased release of growth hormone. Also, the increased levels of glucose, so in case of patient with diabetes, then this will lead to decreased release of growth hormone, as well as aging and obesity. Now, talking about the effects of growth hormones, as we said, that's an anabolic hormone, so it promotes growth. And the way it does this is actually by many effects. I just wanted to mention the main ones that you at least need to know. It increases the uptake of amino acids, which will lead to increased protein synthesis, and this is very important to produce the DNA and RNA and increase the cell number and size and every other thing that is necessary for growth. And it also decreases glucose uptake in the body, and it increases lipolysis. This is the main effects that you should at least know about the growth hormone. Now, talking about conditions that are associated with growth hormone, first of all, gigantism. Gigantism is due to hyperfunctioning, as we said, of growth hormone, and the key word here is that it is a symmetrical growth. So there is symmetrical growth, which is not seen in acromegaly, where in acromegaly there is asymmetrical growth. So what I mean by symmetrical growth is that you can see here in this picture, the patient arm span is like a half of the height of the person that we see in this picture, and this is usually the case in the normal people or the patients that doesn't have gigantism. But in case of gigantism, the arm span will be the same as the height, or even more, or almost the same as the height. And this is the case in gigantism, which is not seen in acromegaly. So the reason for these differences between acromegaly and gigantism is that the excessive release of growth hormone in gigantism usually occurs before adolescence. And the reason we say before adolescence is because this excessive release of growth hormone occurs before the union of epiphysis with the shaft. So as we know, as the child starts to grow, his epiphyseal plate will start to fuse with the shaft and become ossified, as you can see in this picture. That before adolescence, in childhood, there is epiphyseal plate which is separates the metaphysis from the epiphysis. This is the epiphysis, as you can see, and this is the metaphysis, and this is the diaphysis. And here you can see that as the person grows, the epiphysis and the metaphysis starts to fuse together and become ossified as one, the bone density in both are similar. And when there is excessive release of growth hormone before this process to start to occur, then the patient will most likely have gigantism. And we should note that 10% of the patients will develop diabetes because they usually have hyperglycemia and glycosyluriria. A person will also have an overstretch of most organs. As you know, this is symmetrical growth of everything basically. So there will be overstretch of organs, and in the beginning of the condition, the organs will be actually strong, but as the person grows and later in life, these organs become weak due to the overstretch, and this will lead to their damage or rupture later in life, which can make many difficult complications later in life. The treatment for this condition will be somatostatin analog, which, as we said, is the growth hormone inhibiting hormone, or surgery to decrease the bone size. Now talking about acromegaly, so as we said before, there will be asymmetrical growth in acromegaly, and this means that the arm span will be less than the height, as can be seen in a normal person, except that the acromegaly patient will appear very much more enlarged than the normal person. And the reason for this asymmetrical growth is that unlike the gigantism, in acromegaly, the excessive release of growth hormone will occur after the epiphysis union with the metaphysis and the rest of the bone shaft. So this will lead to thickening of all the bones, but not their length. So the length of the bones will not increase, but the thickness of all bones will be increased. The periphery, such as the hand and the legs and the fingers of the hands and the legs, will be enlarged. The skull will be box-shaped, so the patient will have a prominent cheeks and protruded jaws and separated teeth. And patient will also have left ventricular hypertrophy, which can lead to diastolic dysfunction and possible heart failure later in life. Patient will also have a hypertrophic arthropathy, and this will be due to the degeneration of articular cartilage and pre-articular bones, because in acromegaly the patient's synovial cartilage and articular cartilages will also grow and be hypertrophied, and this will lead to increased or excessive friction between them, and this can lead to their degeneration. Now, patient will also have deepening of the voice because of the laryngeal soft tissue growth. Patient will also, as seen in gigantism, will also have hyperglycemia due to the exhaustion of the beta cells. and patient will also have bitemporal hemianopia, and this is due to the compression of the pituitary adenoma on the optic chiasm. The patient will also have hypogonadism and galactorrhea, and this is probably due to the similarity between the chemical structure of the growth hormone and prolactin. Now, talking about how to diagnose acromegaly, so there is what's called a glucose suppression test. The glucose suppression test is a test that's used to diagnose growth hormone related diseases, and this is the way this test occurs is that we administer glucose and look for the response of insulin growth factor like 1 due to the glucose levels. And the reason we look for the response of insulin like growth factor 1 and not the growth hormone response to the glucose is that the growth hormone in nature is usually pulsatile in nature. So what I mean by that, sometimes it is released in excessive amounts, sometimes it isn't in normal amounts. So sometimes if we detect or try to measure the levels of growth hormone in the body, then sometimes it can be normal and sometimes it can be in excessive amount. But if we administer glucose, but this is not seen in the case of insulin-like growth factor 1, which can always be elevated. So if we administer glucose, then we see that the patient insulin-like growth factor 1 is decreased, then this means that there is no acromegaly because the suppression test was successful. There was suppression. This means that there was suppression of insulin-like growth factor 1 by glucose. But if there was no suppression, meaning that the insulin-like growth factor 1 levels did not change with the administration of glucose, that this means that the diagnosis is confirmed of acromegaly. Now, the treatment will be giving basically somatostatin analog. Now, talking about the diseases of hypofunctioning of the pituitary of the growth hormone. So, dwarfism, which is the condition that occurs due to the hypofunctioning of growth hormone, which, as we said, is defined as the short stature of 100 to 120 centimeters. And this can be caused by generally 3 reasons. The first is growth hormone releasing hormone deficiency. The second is the deficiency of growth hormone itself. And the third is genetic mutations that leads to insensitivity of the growth hormone receptor. And this is the most common type between the 3. Now, I just want to mention before talking further that the growth hormone receptor insensitivity type is associated with increased growth hormone levels, but decreased levels of insulin growth factor 1, which makes sense because, as we said before, that the growth hormone stimulates the liver to release insulin growth factor 1, and it does that by binding to the growth hormone receptor in the liver. So if there is insensitivity of the receptor of growth hormone in the liver, then this means that the growth hormone will not be able to produce its effect on the liver, and this means that there will be decreased release of insulin-like growth factor 1 by the liver. So we should know that dwarfism, the achondroplasia, or the insensitivity of the receptor type will have increased growth hormone levels. Now, talking about the growth hormone deficiency type, patient will have symmetrical dwarfism, which means that the head and the trunk are proportionate with the rest of the body. As you can see in this picture, this is Hezbollah. I think most of you know about him. Right now he is 21 years old, but you can see that he looks like the body of the baby. As you can see, the head is symmetrical with the other parts of the body, and this is due to the deficiency of the growth hormone. But now talking about the most common type, which is the insensitivity of the receptor of the growth hormone, which will lead to asymmetrical dwarfism. The asymmetrical dwarfism, so you can see this is Tyrion Lannister in growth hormone. In Game of Thrones. As you can see, I think most of you know about him, that he have the type of dwarfism which is called achondroplasia, and you can see that the head and the trunk growth is normal or not symmetrical with the rest of the body, which means that if you cut the head of Tyrion Lannister and place his head on a normal person's body, you will see that it fits symmetrically. It is the head itself is of normal growth, and the trunk as well. The trunk also is of normal growth. If you cut his limbs, the hands and the legs, you can see that it looks as if it belongs to a normal person, and this is what it means by asymmetrical dwarfism, which is also called achondroplasia, which occurs due to insensitivity of the receptor of growth hormone. The treatment for both conditions will be synthesized growth hormone by E. coli. So we use a recombinant DNA technology to produce, to make E. coli produce growth hormone, and we take that growth hormone and administer it to these patients. But the main thing here is that we administer it as early as possible, or we diagnose it as early as possible to be able to administer it as early as possible to prevent the progression of the disease.